Hey everyone, welcome back to the Weekly Shot, your roundup of what's moving the needle in the world of GLP-1s. I'm Charles RMZ. Today, big stories in the world of GLP-1 drugs, everything from new policy shifts to what celebrities are doing and how this is changing access and perception. Let's dive in. First up, the US FDA has ramped up its scrutiny over imported GLP-1 drug ingredients, especially the active pharmaceutical ingredients or APIs. There's now a green list of foreign suppliers that meet U.S. quality standards. If you're not on the list, your ingredients could get held up or even detained at U.S. ports. The aim here is to reduce the risk of counterfeit or substandard products, especially given reports of people purchasing unverified OG or generic versions. Also, the FDA is warning consumers and healthcare providers about products labeled research use only being misused for self-medication or weight loss outside of approved channels. This is important because there have been a few accusations that some compounding pharmacies have been using research-grade APIs which are not meant for human use. Why this matters: quality, safety, and trust. As demand for GLP-1 skyrocket, oversight gaps can lead to health risks. For prescribers, this could mean shortages or delays. For patients, it could mean potential harm. In other regulatory news, the World Health Organization has officially added GLP-1 medications used for treating type 2 diabetes to its model list of essential medicines. These are drugs from manufacturers like Novo Nordisk and Eli Lilly. The inclusion specifically targets diabetic populations with comorbidities such as cardiovascular disease, obesity, chronic kidney disease, and not just obesity alone. WHO has called for the uptake of these medications in global primary care systems while encouraging development of generics to lower costs. For many lower and middle income countries, being on this list opens up the door for greater access. Here's something tugging in two directions. GLP-1s are increasingly viewed as cost-effective, but payers are already feeling the financial strain. A recent report from ICER, or the Institute for Clinical and Economic Review, finds that semaglutide, like Ozempic or Wegovy, and tirzepatide, like Mounjaro and Zepbound, may be cost-effective, particularly when compared to other weight loss or lifestyle-only interventions. However, coverage decisions remain contentious. The high upfront costs, demand, and long durations of treatment mean insurers are still trying to figure out how to make coverage sustainable. ICER estimates the current U.S. annual net price for Novo's semaglutide to be approximately $6,830, a significant decrease from $13,618 in 2022. Lilly's net price for tirzepatide, on the other hand, is around $7,973, with a list price of approximately $13,000. Notably, both pharmaceutical giants currently sell their products directly to consumers at an average annual price of around $6,000. The implications here: patients may gain access but may also face higher premiums, stricter eligibility, co-pays, or lose coverage unexpectedly. Policymakers and insurers will need creative funding or reimbursement models. Big business move here. Novo Nordisk, the maker of drugs like Ozempic and Wegovy, is planning to cut roughly 9,000 jobs, about 11% of its workforce. 5,000 of these job cuts will occur in Denmark, Novo's home country. These cuts will begin immediately, and they hope to save $1.3 billion per year starting in 2026. The company cites rising competition, notably from Eli Lilly, as one major reason for the cuts. Also, some of their newer obesity drugs haven't performed to expectations yet. Cost cutting is part of their plan, but also they've revised some forecasts downward in light of market pressure. Novo is also looking at other measures to achieve cost efficiency. Here's an emerging frontier: long COVID. The NIH's Recover initiative is planning clinical trials that include testing GLP-1 drugs like tirzepatide, among other therapies, to see if they help with long COVID symptoms. It's not clear yet which symptoms or patient populations may benefit. These trials are important because many people with long COVID report weight or metabolic changes, fatigue, inflammation, and the question is whether GLP-1s could help beyond what we currently use them for. And now a story that shows the power of celebrity in shaping public behavior around health. Recent data shows which stars' emissions of GLP-1 use triggered the biggest jumps in appointment bookings. Here are the highlights. Whoopi Goldberg tops the list after she discussed using Mounjaro on her show The View in March 2024. There was a 29% increase in GLP-1 related appointment bookings on ZocDoc. Partly that was when Wegovy also got FDA approval for cardiovascular risk reduction in overweight or obese adults. Serena Williams comes in second on this list. In August 2025, she launched a campaign with Ro, sharing her 31-pound weight loss using a GLP-1 medication. In the 72 hours after the announcement, ZocDoc saw a 27% jump in bookings. Oprah Winfrey takes the third spot. Oprah had previously made headlines when in December 2023, she admitted to using a GLP-1 medication. Those 3 days, immediately after her announcement, saw an increase of 18%. Then there are other cases. Kelly Clarkson, around a 6% rise after her admission. Meghan Trainor oddly preceded an 11% decrease. Timing, messaging, what drug and what regulatory environment seems to all influence how people respond. Here's why that is interesting. It shows that celebrity disclosure isn't just buzz, it moves behavior with measurable impact on healthcare seeking. It also underscores how complex this field is. A celeb's announcement can help destigmatize or educate, but public perception, media framing, and concurrent policy or regulatory shifts amplify or diminish the effect. It also raises questions: are people going to providers without full info? Are doctors prepared? And what about equity? Do all communities respond in a similar way? Now, here's a big regulatory story that ties in directly with GLP-1s because promotional practices on social media and drug ads play a huge role in public perception and demand. Here's what the administration is doing. President Trump signed a memo directing the FDA and other agencies to crack down on deceptive pharmaceutical advertising on TV, websites, and on social media. One specific target is the Adequate Provision Rule from 1997, which lets advertisers give only a brief summary of risk in ads, with the rest of the details located elsewhere, such as on websites or in print material. The administration wants this loophole closed. The FDA is issuing roughly 100 cease and desist letters to companies with allegedly misleading drug ads, plus thousands of warning letters. Now, there are some hurdles here. First, there's legal and First Amendment issues. Advertising is protected speech. Any regulation that's too restrictive risks legal pushback. There are staffing issues at the FDA. The division that handles advertising enforcement has seen cuts. Less staff could slow investigations or enforcements. And then there's the rulemaking timeline. Changing rules like revoking the adequate provision is slow. There are public comment periods, the possibility of legal challenges, and the complexity of implementing across media, such as TV, social media, and telehealth. It won't happen overnight. For example, a rule requiring simpler and clearer language in drug ads that was implemented last year took 15 years to implement. And then there are new actors and loopholes. There's influencers, telehealth companies, specialty pharmacies, and compounded drug sellers. Some are not clearly regulated under current FDA rules. Some oversight falls under FTC or other authorities. Implications for GLP-1s are these medications are often featured in weight loss, obesity, or metabolic health contexts. Ads, especially from telehealth or influencer channels, may exaggerate or understate the risk or efficacy. Stricter rules could reduce misleading promotion, but also could reduce visibility or make marketing more expensive, possibly affecting new drug adoption or patient awareness. So pulling it all together, here are the key takeaways from this week in GLP-1 land. Safety and supply are under more regulatory scrutiny, which protects patients but could lead to access issues. Global access is inching forward with WHO's essential medicine status. The financial side is both promising, cost effectiveness, and daunting, budget stress. Competition is heating up among manufacturers, which might lead to innovation or price shifts. Public figures have huge sway. Their stories ripple into actual healthcare behavior. Here's what to watch next: how insurers adjust policies around long-term use, such as when to start and when to stop these medications, outcomes from the NIH's long COVID trials involving GLP-1s, whether WHO's move leads to more generics, licensing deals, or pricing pressures, celebrity disclosures, especially from less visible communities, and how that changes uptake and disparities. That's it from this week's GLP-1 Roundup on the Weekly Shot. If you like this video, hit subscribe and leave a comment, and don't forget to hit the bell so you don't miss what's next. Thanks for watching, and I'll see you next week.